Hemophilia A, A Molecular Perspective of Bleeding Disorders by Fatima Said. With complaint, an 11-year-old boy presents with recurrent knee swelling after minor falls, large bruises, and a history of prolonged bleeding after dental extractions. The current bleeding and bruising is the chief complaint, and signs are soft tissue hematomas, prolonged post-traumatic bleeding, possible intracranial hemorrhage, poor healing, and hemothrosis. Differential diagnoses are hemophilia A, factor VIII deficiency, leukemia, von Willebrand disease, liver disease with impaired clotting factor synthesis, and immune thrombocytopenia. Signs and symptoms of hemophilia type A are bleeding, either spontaneous or after trauma, especially on large joints such as ankles, elbows, knees, arthropathy, bruising, intracranial bleeds, poor healing, bleeding into internal organs that could be life-threatening, and painful and disabling hemophilic arthropathy. Here's an image of bruising that is common in this type of patients. This is hemothrosis on patients with hemophilia that can lead to arthropathy. This is an MRI of a 15-year-old boy with hemophilia after having recurrent bleeds on the joint of his knee. And we can see that there's cartilage loss because of the constant bleeding in the area and possible arthropathy. Here are some signs and symptoms. Now, hemophilia. There are two types of hemophilia, hemophilia type A and hemophilia type B. Hemophilia type A is the deficiency of factor VIII, and hemophilia type B is the deficiency in coagulating factor IX. Now, hemophilia is an X-linked bleeding disorder caused by mutations in the genes encoding coagulation factors. In the case that we'll be studying is hemophilia A, and it's factor VIII that's not encoded properly. Now, because it is an X-linked genetic disorder, males are affected by it and females are not affected but can be carriers. Now, hemophilia A is the most common type of the disease. There's a prevalence of 1 in 5,000 births, male births, and hemophilia B is 1 in 30,000 male births. Now, the disease severity of hemophilia is classified according to the plasma levels of factor available, right? In the factor activity. The severe form is defined as a factor level of less than 1%, and those severe cases are very rare. Now, the moderate cases are between 1% to 5%, and the mild cases are between 5%, more than 5%, but less than 40%. Patients with severe hemophilia frequently develop hemorrhages into joints, muscles, and soft tissues. And those that are in the severe spectrum, they are more likely to endure intracranial hemorrhages, more spontaneous bleeds that can be life-threatening. Now, here are just some differences between hemophilia B and hemophilia A. Now, we're going to talk about the pathophysiology of hemophilia A and how the coagulation cascade is distorted by this disease. Here's an image of how the coagulation cascade takes place, and we'll discuss normal coagulation cascade, intrinsic pathway. Factor VIII and factor IX contribute to a complex cascade of clotting proteins ending in the formation of a strong fibrin clot at the specific site of injury where there's bleeding to start hemostasis. And this is initiated upon a breach of the endothelium of blood vessels. This enables tissue factor to make contact and activate factor 7. After factor 7 is activated, it initiates a limited cascade that's independent of factor 8 or 9 and produces a small amount of thrombin. Thrombin is a crucial component of this early clotting process, which it includes an activation of platelets to come to aggregate and plug the collagen-exposed endothelial surface. This collagen also attracts the platelets to the area molecularly. And this is also facilitated by the von Willebrand factor. When this happens, blood flow slows down, primary hemostasis starts, and there's also a small converting there's a converting of small amounts of platelet bound fibrinogen into fibrin, and fibrin begins to form the clot. Now this is just the primary process of hemostasis as the bleeding starts to slow. And here's an image just showing the cascade of the intrinsic pathway that we're focusing on. There's also the extrinsic pathway. Here's another image as well. Now, in this second phase, the amplification phase, there are different roles, and this is where the factors start to be activated. So, the phospholipid membranes of these adhere platelets that came in are the surface or the canvas where the following cascade of clotting factors takes place, and it includes factor 8 and factor 9, and they're anchored there, facilitating the amplification and subsequent propagation of thrombin production to effect a thrombin burst. During this secondary hemostasis, increased amounts of fibrinogen are converted into fibrin to stabilize the forming thrombus. The factor 8 circulates in an inactive form and is bound in a D3 domain as a chaperone protein of von Willebrand, and as such is kind of confined on the intravascular compartment of the von Willebrand. Von Willebrand is a large and multi-domain clotting plasma protein that is important, very important on platelet adhesion. And it's localized mainly on the primary hemostasis. Now, upon thrombin activation, factor 8 undergoes a proteolytic cleavage, and there's some position change. Cleavage is formed in the PARG372 and PGARG1689 positions, and this is essential for full factor 8 activation. And then factor 8 becomes factor 8A. This cleavage exposes a functional site within A2 domain, and that is required for the interaction with factor 9 activated, which is hidden in the inactive form of factor 8. Now, factor 8 activated uncouples from von Willebrand with a subsequent change, and it's almost like sliced in three. So factor 8, once activated, binds to the negatively charged phospholipid surface where the platelets have created this plug and are aggregated. This light type of chain, a light chain of C1 and C2 domains. The presence of early fibrin production enhances this binding. The platelets bound factor 8 now activated provides almost like an anchor for enzymatic complex. This is the tennis complex, and also factor 9 activated and factor 10 as well. Now we can continue on the process. Now, in this step, the 10x complex formation happens as a result of factor 8 activated that provides an anchor for an enzymatic complex to happen, consisting of factor 9 activated and it places the enzyme, and factor 10 as the substrate. Now, this complex accelerates the conversion of factor 10 into factor 10 activated, and it's done faster. Factor 10 activated then combines with factor 5 activated to form prothrombinase complex, which converts prothrombin factor 2 into thrombin, that is factor 2 activated. This leads to a thrombin burst, producing a large amount of fibrin to form a stable cross-link clot. And this is the secondary hemostasis. Now, without factor 8 activated or factor 9 activated, this tenets complex cannot form properly. In the factor 10 activation is reduced, there's less thrombin that is produced, then less fibrin produced. It's either weak or incomplete, and it results in a weak poor clot formation. There's a process of clot formation with the factor cascade and the platelet aggregation. A little bit of the pathophysiology again. Factor 8 is a large molecule, a large protein, and is a blood clotting protein mostly produced in endothelial cells in the lining of the vessels, not on the liver as previously was thought. It travels attached to von Willebrand, and von Willebrand protects it from breaking down. Factor 8 itself is inactive until bleeding happens. Now, factor 8 works during during clotting, as once the vessel is injured, thrombin activates factor 8 by cutting it at a specific spots, then activates its form activated, separates from von Willebrand and attaches to the surface of platelets in the injury site. Once that happens, factor 8 activated acts as a helper for another cofactor like factor 9 activated, and together they form the 10x that we explained, and this leads to thrombin formation, and the enzyme creates fibrin, and this maintains a stable clot. Now, if this fails, if this process fails, we see that there's prolonged bleeding, spontaneous internal bleeding, and the symptoms that we see because there's a weak clot formation again. Now, what causes this disease itself? It is a mutation of the gene that codes for factor 8. Now, this gene codes for 2,332 amino acids of the factor protein, and is located on the end of that long arm of the X chromosome. It's very large. It contains 26 exons. Now, there are different types of mutations that cause hemophilia type A. There's the point mutations, deletions, insertions, but especially the null mutations seem to have the more severe cases of hemophilia type A. Some patients are CRM positive, meaning that the factor A is present, but it's not functional at all. And in some cases, there's a novel mutation where the patient just experiences this mutation on the gene within one family generation or themselves. It is 30 to 40% of those cases. And we'll continue with the presentation. Now, interim 22 inversions are most common causative defect of severe hemophilia A, and is also 40% of the cases. Happens in male meiosis or sperm formation. The X chromosome loops and misaligns, causing intron 22 segment to flip or invert on itself. And then 30 to 50% of hemophilia A and B cases happen as novel mutations rather than just inheritance. A negative family history does not rule out hemophilia. There's also a point mutation there, myosin factor A genotypes that are responsible for most mild cases of hemophilia A. Now, some clinical manifestations across the lifespan. Patients with severe hemophilia are diagnosed around age 2 years old, but there's an average too of other severe cases sooner, like within 12 to 18 months of age. During childhood, we see most of the signs of bruising and hemarthrosis. Now, during adolescence, there is just dealing with chronic joint disease and trying to avoid that disease, given the constant um, bleeding within the joints. And during adulthood, there's the joint disease itself, the arthropathy. There's risk of hepatitis C and HIV, giving us a risk from transfusions or even from um, the the factor administered to patients. But with technology now, those cases are very rare, but still a possibility in like underdeveloped countries or mostly in the past. Here with laboratory testing and diagnostics, we have the APTT, and it will be prolonged to just showing that the intrinsic pathway is defective. This is involves the factor 8, factor 9, factor 11, and factor 12. There's also a PT, and the INR will be normal, as well as the platelets. The fibrinogen count as well will be normal. However, for definite confirmation, factor 8 activity assay is the test to do. And there's two parts to it. There's the stage one, and then there's the chromogenic. They're usually done together just to have more accuracy. And if there's a chance to check any sort of mutations, there's the genetic analysis, and it can also be done prenatal as well to check any sort of um, mutation there. And it points out deletions, insertions, and point mutations. The mixing studies show if there's any sort of lupus or like autoimmune destroying factor 8. Here's a table with all the tests available. Treatment options available are the recombinant factor, factor 8, and it's just a replacement of the factor. There's the imicumab medication. It's a new medication that has a longer half-life of a month, stays in the body for like 7 months in average, and it could be a long-term type of therapy. There are antifibrinolytics as well, and gene therapy that gives the option of a possible cure through endogenous production of factor 8 following a transfer of a functional copy to the gene. Non-pharmacologic options are injury prevention, physical therapy for joint protection and avoiding NSAIDs and aspirin. Cultural and sociocultural considerations are the high cost of the factor in low-income countries or third world countries, the stigma and limited self-awareness in cultural settings. Jehovah's Witnesses might decline blood-derived products in the historical context of HIV and hepatitis infection on patients with previous treatments. Overall, patients with hemophilia type A have a good prognosis to a near normal life, especially on mild cases. But without treatment, there is severe morbidity. Hemarthrosis and bleeding complications are still the main cause of morbidity. Occasional signs of bleeding is important, vaccinations, and the use of subcutaneous route as well, and the importance of adhering to treatment. Thank you.